INT'L.
Inflammatory bowel disease, IBD, is a term for two conditions, Crohn's disease and ulcerative colitis, that are characterized by chronic the inflammation of gastrointestinal GI tract. Ulcerative colitis features limited to the large intestine and the rectum. The inflammation occurs only in the innermost layer of the lining of the intestine. It usually begins in the rectum and lower colon, but may also spread continuously to involve the entire colon. Ulcerative colitis symptoms include, as the lining of the intestine becomes inflamed and ulcerated, it loses its ability to adequately process food and waste or absorb water, resulting in diarrhea, crampy abdominal pain, urgent need to move bowels, sensation of incomplete evacuation, rectal bleeding, anemia if unchecked. The longer the person with ulcerative colitis remains in remission, the less likely the patient is to experience a flare-up of the disease in the following year. Crohn's disease features can affect any part of the GI tract, from the mouth to the anus, but most commonly affects the end of the small intestine, the ileum, where it joins the beginning of the colon. May appear in patches, affecting some areas of the GI tract while leaving other sections completely untouched. The inflammation may extend through the entire thickness of the bowel wall. Crohn's disease symptoms include, as the lining of the intestine becomes inflamed and ulcerated, it loses its ability to adequately process food and waste or absorb water, resulting in diarrhea and abdominal cramps, bloody stools, ulcers formation in the colon and rectum, fever, urgency to have a bowel movement, weight loss, risk factors of IBD, genetic predisposition, immune system disturbance, environmental triggers, smoking, antibiotics, non-steroidal anti-inflammatory drugs, and appendicitis. IBD complications: diarrhea and rectal bleeding, perforated bowel, toxic megacolon, skin and bones. IBD has a significant impact on quality of life. 67% of respondents frequently considered the availability of toilets when planning to attend an event. 60% felt stressed or pressured about taking sick time during IBD. 48% felt that their life was affected by IBD symptoms, even between flare-ups and remission. IBD burden. IBD can significantly affect a patient's quality of life. IBD has emerged in newly industrialized countries. From 1990 to 2017, the prevalence of IBD increased by 85% globally. More than 10 million people are estimated to be living with IBD worldwide. Having a chronic illness such as IBD can be emotionally burdensome, feelings of anger, anxiety, or fear and depression. IBD results in a significant financial burden. IBD is associated with both direct and indirect costs.
All right, well, hello everyone. Good afternoon to all of you, and I guess good morning to our colleagues from across the Atlantic. It's my pleasure to welcome all of you again to this second IBD Grand Round. Again, we're featuring two of our regional experts who will be presenting cases that will be also discussed and moderated by our two esteemed faculty from Cleveland Clinic, Dr. Florian Reeder and Dr. Benjamin Cohen. What I wanted to just do in the first minute is just to share with you some information about the first Grand Round, which we did a few months ago. I can't see the slides, but basically, if I can have the slides, Nancy, can. All right, so we held the first event, or our inaugural event, on March 15th, and I thought it was a good event, good start. We had two nice cases presented by my team at AUB and also by Osman Al-Harbi from Saudi Arabia. We had a good number of attendees. I think I had more than 120 attendees. A lot of them were from Lebanon, but also from all over the Arab world. We've also expanded our board, and now we have some people from Egypt. And the evaluations across the board were all essentially very good or excellent. So I think we're on to something really good, and hopefully we'll continue with this trend. So I'll pass the mic or the stage on to Florian, I think, who will be presenting our first speaker, Dr. Zahir Kutubi, and our second speaker will be Dr. Talal Al-Tawil from Kuwait. Thank you.
Thank you very much, Professor Sharara, and congratulations on the success of the first version of this event in the Middle East. I was very impressed, in fact, with the discussions with you from the Cleveland Clinic, together with Dr. Cohen, and support you building out this program. So we have, like last time, two case presentations, and we then discuss with your expert faculty together the best approach to patient care. And the first case will be presented by Professor Kutubi. He's a consultant for gastroenterology and hepatology at the Cleveland Clinic Abu Dhabi, and is a clinical assistant professor of medicine at the Lerner College of Medicine in Cleveland, Ohio, and where we are located. He's also an adjunct clinical associate professor of medicine at the Khalifa University College of Medicine and Health Sciences. And he has a very challenging case for us. And afterwards, we are happy to dive into the case discussion. So Professor Kutubi, please.
Thank you so much, Dr. Okay, so thank you very much again. I will be starting this very interesting case of Crohn's disease, and I think at the end of the discussion will be a discussion of this of the case. So basically, this is a 53 years old gentleman who presented to GI clinic with anal and right lower quadrant pain. The onset was 2 to 3 months. It is associated with nausea, vomiting, diarrhea, and hematochezia. Significant weight loss of 10 kilograms aggravated by excessive eating. Now, the gentleman has significant history of Crohn's disease since 2000, and his last colonoscopy in 2017 outside hospital showed normal colon, but they could not access the terminal ileum. He had history of elevated liver function test after taking Imuran, history of cholecystectomy, appendectomy, and asthma. Had also significant family history. His mother and daughter both are, they have Crohn's disease. His father had prostate cancer. He's a former smoker, quit smoking more than 10 years ago, occasionally used alcohol, denied any drug usage, and actually he worked as a hospital administrator. Now, when you look at the physical exam, blood pressure 142/80, a little tachycardic pulse of 90, afebrile, respiratory 17, but we can appreciate a very low body mass index of 19. Appeared malnourished, weak, tired looking. On the abdominal exam, he has periumbilical pain, also in the right lower quadrant. No rebound tenderness, but you could feel a fullness in the right lower quadrant, which was painful. Also, he had a painful rectal exam and was very much resisting, actually, the exam because of pain. Now, as most of the IBD patients, he was hypoalbuminemic. Albumin was 29 with a hemoglobin of 10, white count 4.6. He had high platelet 438. His fecal calcium more than 1,000, had normal liver function test and normal urea and creatinine. So, we diagnosed him with Crohn's disease because of the symptoms he presented with nausea, vomiting, suspected bowel obstruction, and because of the significant pain during the anal exam, we suspect, having a possible perianal fistula. Now, sorry, just 1 second. So when we did also go ahead and we did a colonoscopy, and the perianal and digital exam was painful. There's a mild stenosis which was passed by the digital rectal exam. Again, suspected the possible fistula because of that pain. The colonoscopy showed a perianal fistula. We will see the pictures very shortly. Rectal stenosis, which was passed by the pediatric scope, diffuse ulcerations in the rectum and the descending colon, and the ileocecal valve appeared inflamed and strictured, which could not pass through the pediatric scope. So this is the pictures of the colonoscopy, and you could appreciate here the opening, and that was the perianal fistula. This is the rectal stenosis area, which again was passed through the pediatric scope. Again, the same area of the rectal stenosis. This is the diffuse ulcerations he had mainly in the rectum and the ascending colon. And here you go, the ileocecal valve, which was very much stenosed and fibrotic, and we could not go through. I tried the pediatric scope, but we were not able to go through. Also, we do usually either an MRI enterography or a CT scan enterography. And in the distal ileum, actually, there is a 5 centimeter short segment of, now was described as inflammatory stricturing segment with mucosal enhancement and submucosal fatty deposition. Also, there is a short segment of inflammatory change communicating between the two loops, which actually could represent a small enteric fistula. And also it was significantly seen a pre-stenotic ileal distension and dilatation. And when we look at the CT scan, you can appreciate very much the stenotic area seen by the arrows and the significant dilatation of the area above it. Here's another view. Also another view. You could see there's a little, opening, but not significant stenosis. So when we have a diagnosis of Crohn's disease with ileocolonic involvement, with the small bowel obstruction, with ileal fistula, and with perianal fistula also. So very complex kind of a patient. So discussion, so now we know for sure that the patient has partial bowel obstruction with terminal ileum stricture. Now, whether that's acute or chronic or acute on the top of chronic. Patient cannot take azathioprine because of history of elevated liver function test, never been on biological treatment before, and patient not very encouraged to discuss any surgery at this time. So again, here we come to the questions is what is the best treatment at this point? Now, whether to start steroids or to put him on anti-TNF, to put him on methotrexate because he cannot take Imuran or azathioprine, whether to start Vido or ustekinumab, or to take him directly to surgery. So what we did actually, patient was admitted, was started on IV steroids. Later on, he was discharged. Now, because of insurance issues, we would love to put him on infliximab, but because of insurance issue, we had to put him on adalimumab initially. We followed him, did not do very well despite following the TDM, and his levels actually did not reach above 5, and clinically he was not doing well. We repeated laboratory test and colonoscopy again did not give him any improvement. So we discussed in our IBD meeting, it's a multidisciplinary attended by also colorectal surgeon, radiologist, pathologist, and we decided to admit him to reach for nutrition consultation, to put him on TPM because he is, malnourished with the very low BMI, to put him on infliximab, and to obtain a surgical consultation for their kind opinion regarding the small bowel obstruction. Now, later on, patient was discharged home to be followed in the outpatient clinic. Now, 4 weeks after discharge, patient presented to the emergency room with significant pain, nausea, and vomiting. And you can appreciate the X-ray of the abdomen, which showed actually air under the diaphragm. So basically, the patient was perforated and he was taken to surgery, which showed diffuse peritonitis, large amount of food content due to small bowel perforation at the mesenteric side, plus 2 centimeter perforation located 2 meters from the detritus ligament. In the ileum, there's 5 strictures which are not suitable for strictureplasty. Now, we come to the end of the presentation for the discussion. Now, the question is, was starting infliximab the right decision, or should patient, have been sent to surgery before starting the anti-TNF? What is the criteria for sending this patient to surgery before starting biologics? In general, if there's any data linking infliximab to the perforation which happened, and what other biologic lead to the similar incident like perforation?
Yeah, thank you very much. That maybe we stop here for the discussion, yes, before we then dive into the summary, yes, at the end.
Yes.
Thank you very much, Professor Kutubi. I'm happy to be joined today on the panel to discuss this case by Professor Sharara, who introduced and is leading this entire series from the AUB in Lebanon, from Professor Sanur from the St. Joseph Hospital in Lebanon, Professor Cohen, my co-section director for IBD at the Cleveland Clinic, Professor Elouali from the Cleveland Clinic Abu Dhabi, Professor Al-Mutardi from the King Faisal Specialist Hospital in Saudi Arabia, and then Professor Murad also from AUB. So a distinguished panel to discuss the approach to this patient. So I want to start, in fact, with very basic questions and to wind back to the beginning of the case. And let me start with Professor Elouali. So the patient came in with a low albumin, low hemoglobin, a potential need for surgery. How do you optimize the patient nutrition-wise? And then what is your approach to anemia in a patient with Crohn's disease?
Yeah, thank you very much, Florian, for bringing it up. And thank you, Zahir, for the case, challenging case. So indeed, at the very beginning, so the patient looked like he was quite hypoalbuminemic, malnourished. And so the first steps really would be to consult nutrition, have their support in terms of nutritionally optimize the patient as much as possible. Of course, correct the anemia with some IV iron as well. And then really have an honest discussion with the patient at that point. And I don't know if you want me to get into this, but what are the next steps? And with a CT scan showing already a fistula, I think you really have to have an honest discussion with the patient that, listen, surgery is going to happen. The question is more the timing. And then once we really optimize him nutritionally, And definitely infliximab would have been an option at some point anyway because of his perianal disease. And so I think the question is, do you start with surgery and then you follow that with infliximab? Or do you start on infliximab, nutritionally optimize him, and then go for surgery once he's ready?
Mm-hmm. So Dr. Cohen, you have published extensively in perioperative optimization, perioperative care of patients with IBD. When do you think a patient would then be ready for surgery? When you optimize, you have nutritional support, in this case TPN, patient is obstructed. When do you say it's okay, you give green light from your side for surgery?
Well, I mean, it's a complicated discussion between the patient, the surgical team, the nutritionists. I think, you want to balance taking the time to get them nutritionally optimized with the ongoing symptoms and obstruction you're dealing with. So, I think there's no one right answer for all patients. I think this is where we have shared decision making. I think generally 2 to 3 weeks of nutritional optimization is usually enough. But if you're dealing with patient has abscess that's not drainable, not responding to antibiotics, then you just have to do the surgery that needs to be done for the patient in a situation like that. If the patient doesn't have an emergent surgical indication where it needs to be done right that second, then you have the luxury of time. And there is also data in cases where you're dealing with, for example, small bowel inflammation, to use exclusive enteral nutrition, for example, in pediatric patients, that's been shown to reduce inflammation. So that could have the benefit of improving nutrition while also reducing the inflammatory burden leading into surgery. I think the key thing is you want to try and avoid prolonged high-dose steroids in patients. So if you're requiring high doses of steroids, then I'd rather just get the surgery done in a patient. But again, there's no one right answer to this.
And so we hear, and I agree with you, Ben, completely. We hear from both experts so far, surgery is in the future for this patient. So I'm gonna talk now to Professor Al-Alawi, who I just saw joined, and then before we move to Professor Sanur. So Professor Al-Alawi, this patient has a stricture in the terminal ileum, has internal penetrating disease. Is that a problem for the patient? Does that patient likely respond to medical therapy? And then if surgical therapy is warranted, what type of surgery would it be? Perianal disease, ascending colon inflammation, terminal ileal inflammation, and internal penetrating disease, quite complex.
Hi. I didn't hear I wasn't here from the beginning, sorry, because I'm busy in clinic, but is the internal disease like it's abscessing, internal fistula and it's abscessing, or what is it exactly?
So it's a fistulizing disease, no abscess.
No abscess, so it's just like enteric fistula?
Mm-hmm. Yep.
No genitourinary involvement?
No. Mm-mm.
Okay, so this part should be possibly amenable to medical therapy. Colonic disease is amenable to medical therapy, but if he has a perianal fistula, I think I would just go ahead with a ceton insertion first and then start the medical therapy before anything else.
Do you worry in terms of your decision for medical therapy if there's a stricture downstream of the internal penetrating disease?
So how bad is this stricture? Is this something like it's a long stricture? Are there any obstructive signs? Are we thinking of a surgical stricture or a?
I apologize because I did not see that you died. I didn't see the beginning of the case.
Yeah, no.
So
no.
It is a patient that has a stricture with pre-stenotic dilatation, obstructive symptoms.
Okay. So now it's clear. Yeah. Mm-hmm. So yeah, there is an indication for surgery. Then if there's a pre-stenotic dilatation, there is no role for us to dilate. So surgery for that, surgery for perianal disease, and then medical therapy.
Okay, very good. So another vote for surgical intervention. I think the key point here is we know from observational data that internal penetrating disease upstream of stricturing disease responds very poorly to medical therapy. And then to Dr. Cohen's earlier point, the key is, at least in my opinion, to get the patient as ready as possible to a surgical intervention. And for this, potentially medical therapy as a bridge is an option, but medical therapy will likely not take care of this internal penetrating disease and stricture disease in this patient. So Professor Sanyur, you hear all the experts' opinions, they all say surgery, but the patient says, I don't want surgery. And Professor Kotubi already put all these medical options on the screen, and we can add upadacitinib now also to the list. So do you agree with infliximab or adalimumab? And then if you say yes, which of the two would you choose?
Well, before that, let me just ask you a question and tell me, I've been too old in the field to learn that 30 years ago, they used to tell us steroids, when you have really severe stricturing disease, sometimes could lead to perforation. Does this really is based on something hard, or we should not think about it?
So I'm interested in the opinion of the panel. So in a patient like this with stricturing and internal penetrating disease, I would actually try to avoid corticosteroids. So once you have internal penetrating disease or an abscess, steroids are not only not helping, but also may increase complication rate. If it's a purely inflammatory stricture and you need to bridge the patient to a biologic, I think steroids are an option, but I would try to avoid. Increased perforation rate, I'm not aware with corticosteroids, but you have an increased risk for abscess and increased perioperative complications. And I see Dr. Cohen is nodding his head. Dr. Cohen, do you want to comment?
No, I just agree with everything you said. The data on steroids is clear in terms of the internal penetrating disease, as well as the postoperative complications. It's the #1 risk factor that's consistent across studies. So again, you want to minimize exposure where you can, and certainly it's going to not help abscesses heal. So,
going back to the question, you have the live-rest type of answer, of course, evidence-based, fistulizing disease. We're talking anti-TNF, mainly infliximab, adalimumab. Why not? We have post-hoc analysis with the CHARM studies and the others. So yes, anti-TNF are probably the option, and no data on the others, especially the anti-interleukin 12/23, does not mean that they're not efficacious. We know that with a real-world experience and post-hoc analysis from their trials, it is. And in my personal experience, I've seen a tremendous response with ustekinumab after fistula and rectal disease failing to adalimumab. So yes, it's an option, and I think that we would have started that, all of us, short of discussing the surgery, which I would be interested to see all the experts at the end, what kind of surgery in this case would have been the best, with all the fistulas and the rectal, the ileal, the strictures. It would be interesting to see what kind of surgery would end up this patient having.
That's going to be one of the big questions. And I saw Dr. Cohen's hand up, but before I go back to Dr. Cohen, Dr. Sharara, would you start infliximab monotherapy or combination therapy in this patient? And then perianal disease, internal penetrating disease, what kind of level would you aim for?
Well, I think this is a peculiar case. I think, Philippe just mentioned that, okay, we use anti-TNFs for fistulizing disease, but this patient is not your garden variety patient with perianal disease. This patient has long-standing Crohn's, essentially untreated or neglected for years. He has stricturing, penetrating disease. He has a stricture and a fistula in the rectum. He has enteroenteric fistula. He's malnourished. He's anemic. He's not your typical kind of patient that you see in a clinical trial where you use anti-TNF for perianal disease. So this patient, in my opinion, I would have liked to have more information. I think an MR of the pelvis, the abdomen, surgical consultation, clearly a nutritional consultation, try to help the patient. But this brings me back to Philippe's question. I'm not sure that I would certainly not have used steroids at any point, but I'm also not a bit reluctant, or I'm underwhelmed that anti-TNFs will be able to achieve much in this patient with this long-standing disease. My opinion, but the question really is what kind of surgery? And I think without really detailing the patient's anatomy or where his disease is, because all we have is really a CT showing a portion of the small intestine where there's inflammation, but we don't have anything about the pelvis, et cetera, et cetera. I think the surgical options would be complex, I admit, but I'm not sure that I would be skeptical that anti-TNF would achieve much in this particular patient, honestly, alone or in combination, clearly.
I agree with you entirely. Professor Cohen, you raised your hand.
Yeah, so the one important point I wanted to make here, which is along the lines of what Dr. Sharar was talking about, is that we have to be very thoughtful about how we use the various biologics, particularly infliximab, in the perioperative period. So I agree this patient needs surgery and that infliximab is not going to change that outcome most likely. And what we know about anti-TNF is that they shouldn't really impact surgical outcomes. However, this patient, by virtue of their disease, is at high risk for complications. So the one thing I would worry about would be trying to give them some doses of infliximab before surgery, when surgery is really what they need. Then maybe they have some complication unrelated to the infliximab, which leads to holding the infliximab, not completing their induction, becoming immunized. And certainly with this patient's disease phenotype, they're probably going to need infliximab at some point in their disease course after surgery. So this is where I'm a little more thoughtful about how I use biologics pre-op as sort of like a Hail Mary type of treatment, and rather just go straight to the surgical intervention.
Would you consider, if the patient says, I'm not ready for resection, diverting ileostomy instead of biologics, and then get the patient nutritionally optimized and have further conversations?
I think that's very reasonable. And probably, I agree we need more information about what's going to be the appropriate approach for this patient, but probably no matter what, they'd be looking at a diverting ileostomy, because you'd probably do a small bowel resection for their stricture. They're not going to sign up for a proctectomy. So you're probably going to leave them with a diverting ileostomy and then treat them after you've managed the small bowel obstruction surgically, in the hope that you can have some impact to eventually take down the ostomy, though I think that's unlikely.
Yeah. I mean, my personal approach to this patient agrees with what most people have said is nutrition optimization, get the hemoglobin up, get to surgery as soon as possible, try to convince the patient. And then the big question is going to be, how is the surgery going to look like with perianal disease, internal penetrating disease, stricture disease? Where's the landing zone for the surgeon in the colon if they want to keep the anus intact? How would it look like? Professor Al-Mutardi, before I go back to Professor Kutubi, how would you explain, or what type of surgery would you think this patient would be eligible for, or what would be your approach before we close the case with the perforation question?
Sure. I hope you can hear me well. I have a poor signal. But I would go with an upfront surgery followed by biologics, to be honest. I'm in a patient with penetrating and stenotic disease. I think the evidence tells us a lot that medical treatment would not help the patient much. I would try to refer the patient to the surgeon, optimize him nutritionally with TBN. Maybe consider an examination of the anesthesia with possible ceton placement in the same setting that might help the patient, with a possible definitely upfront infliximab within 4 weeks after surgery, whether the patient was diverted with all or not, depending on his nutrition status, his albumin, and the surgical opinion intra-procedural or intraoperatively. This might dictate actually whether to divert him or not. I know there are different factors that's been mentioned, patient acceptance, but definitely I would be more inclined toward a surgery upfront.
Surgery upfront. Yeah, and my thought, I would be interested in Professor Sharara's opinion or Professor Elewali's opinion. So the surgeon will have a strong weight, obviously, in determining what type of surgery. I would not directly jump towards a proctectomy from the beginning in a biologic naive patient, and I would probably discuss with the surgeon, since the transverse colon on the left side looked good based on endoscopy from Professor Kotobi. I would probably do an ileocecal resection, take what is diseased on the right side, do an iliotransverse anastomosis, send the patient to an EUA with ceton placement, and start on infliximab combination therapy post-op. And since the patient had azathioprine before, I would probably start the patient on methotrexate as a combination, and then have a level of around 15 to 20, perhaps, because of the perianal disease. Is that reasonable, Professor Elouali?
Yes, absolutely, Florian. I think I agree with your approach. I also would address the rectosigmoid disease. I would say anorectal sigmoid disease with infliximab post-op. And, you know, it doesn't look as severe as really what's driving the problems. The malnutrition right now is the small bowel stricturing and fistulizing disease. So I would, you know, once you nutritionally optimize the patient, go for surgery. But definitely before surgery, I think you'd want to know where the small bowel disease is exactly, right? And so that will really guide you towards what type of surgery do we need to do. Is it going to be just an ileocecal resection? Are we going to need strictureplasties? And so approach would be that. And then in terms of perianal, definitely get an examination under anesthesia. And then post-op, we just get ready with infliximab combination therapy.
Very good. Professor Cohen asked the questions in the chat. Would you divert them? I mean, that will ultimately be up to the surgeon, in my opinion, during the surgery. But the likelihood, when I talk to the patient ahead of time, I would consider high for diverting ileostomy after the resection because of internal penetrating disease, stricturing disease, significant inflammation, to protect the anastomosis, and then give the patient a few months and then revert the ostomy.
And perhaps, if I may, more importantly, perhaps, is his pretty severe rectal disease with stenosis and fistula and so on. So I'm not sure that it's only to protect the anastomosis, which would be nice in somebody on steroids or very malnourished, but I think that would open up the possibility for you to improve better the perianal disease response to treatment, give you a break for the patient so they can get the anti-TNFs and recover from surgery.
I agree. Have a head start where you can then revert the ostomy on anti-TNF with improved perianal disease. I agree there would be there's an added benefit to the approach. So the last question for Professor Sanur, and then I hand it back to Professor Kotobi to close the case. So have you seen perforations on infliximab? Has that happened to you before? Is that a concern of yours?
Not really, but I've seen perforations on steroids. So I don't know if it's, you know, the kind of, if we're all GI also, the kind of lymphoma that perforates under chemotherapy. So you have a huge burden of inflammation. And then when the inflammation resolves in one point, then the fistula opens, or I assume this is just mental elucubration, like we say in French, but I haven't seen an infliximab. I've seen it on steroids at least a couple of times.
Professor Cohen?
No, I mean, I think the initial studies, there was some perforations, but that related more to being done in severe disease where what they needed was surgery. And so there was a misinterpretation that it could be due to the anti-TNF, but it was really just, using anti-TNF in a patient whose disease was needing surgery.
Yeah.
Professor Elouali?
Yes, hi. So I think this is a concern that was brought up a few years ago, right, at the onset of when we started to use infliximab. And I really agree with Ben that a lot of it is patient selection. Those patients were really sick. We started on infliximab or anti-TNFs, and then we saw perforations. But thankfully, we've had a lot of data that came after that to kind of debunk that notion that you could get a perforation with anti-TNFs. We also have a recent systematic review that looked at this, and there was really none of that. And then there was the TREAT registry as well. So I think at this point in 2023, we could safely say that it's unlikely to be the cause. And it really depends on the patient. And I think the patient was headed to surgery anyway.
I agree with you. I think the confusion early on was because of the disease severity of the patient that received infliximab. And a comparable situation was with stricturing disease, where people felt infliximab may cause stricturing disease because they diagnosed it when they started the patient on infliximab. But this was also thoroughly debunked, as Professor Elouali mentioned, for instance, through the TREAT registry. So Professor Kotobi, back to you for closing the case, and then Professor Cohen will moderate the second one.
So thank you so much. I think it is a great discussion. Now, I'll tell you what happened to this patient. Basically, he was taken to surgery. He had actually an ileocecal resection. He was not diverted. Our approach initially was actually to take him to surgery, but looking at the CT, and again, it was mentioned as an inflammatory stricture. So that's why, and in addition that he refused the surgery, we have no other option other than put him on steroids and later on to give him some, infliximab. So in our area of the world, basically, if you tell patient surgery, you walk out of the door immediately and go see, looking for another opinion. So again, we need a lot of education. We need a lot of discussion with our patients to believe that surgery, to start with, it is not a bad idea. It might be the best idea for him instead of starting medication. So what I'm going to do, just a few slides, I was trying to search whether there's any link between the infliximab and the bowel perforation. When I did the search, actually there is one case, second, third case. So this is the first case, which is a rare case of free bowel perforation associated with infliximab for stricturing Crohn. This is a Korean Journal of Gastro. And again, this is old, 2013. Another case by Wisconsin Medical Journal. Again, they're describing bowel perforation in a pediatric patient. And again, this is 2016, quite also an old. And another case from Japanese Medical Journal, also an ileal perforation after infliximab. And then I found this, which is basically a case control study published in the colorectal disease, where they're talking about reviewing the operation, the emergency operation between 1999 and 2009, in patients with the Crohn disease who they were checking for free perforation. And so here we go. So 13 patients underwent emergency surgery for spontaneous free perforation. 8 patients, 62%, has been treated with anti-TNF within 5 months of the perforation. So this study showed the higher occurrence of free perforation in Crohn disease with anti-TNF. Again, this is most likely this is all data, but again, I'm trying to see. I get 2 patients who get perforated after anti-TNF, so I can say this is the reason, because as you mentioned, there's many studies which may show that this is not the case. But again, what I get out of this case is, when you believe that this is surgery to start with, you have to convince the patient that this is the best option for the treatment from the beginning. Thank you so much.
Our second case is going to be, again, talking about co-management in a different setting with some of our extraintestinal manifestations. And so I'm going to turn it over to Dr. Al Tawil, who's the head of the Division of Gastroenterology at the Jabr Al Ahmad Hospital in Kuwait, for our second case.
Okay, good evening, everyone. The next presentation will be about ulcerative colitis. So next slide, please. Okay, next slide, some disclosures. So the case we're going to be talking about is we're going to be thinking outside the box slightly, or outside the gut, actually, and talk about a more challenging aspect with our colleagues from the multidisciplinary aspect. So this is a 37-year-old female who was diagnosed with severe ulcerative colitis in 2016 and had a pretty stormy sort of course from the start, failed medical therapy, including steroids, azathioprine, adalimumab, and as well as 1 dose of infliximab, and underwent surgery pretty early on in her disease course, within a year really. And had a subtotal colectomy with an ileostomy in 2017. Unfortunately, it wasn't possible to do a pouch, because this patient has undergone previously an emergency abdominal surgery for a motor vehicle accident. So she had a transection of her pancreas, duodenum, and colon that required distal pancreatectomy, the duodenal and colocolonic anastomoses, and the surgeons found it very difficult to do the pelvic dissection to do her pouch. So she was just really left with a subtotal colectomy. So she had a rectum and a bit of sigmoid actually, and the loop ileostomy. Next slide, please. No, back. Yeah. So I got involved in her care a few years later. She was under the follow-up. So after she had her surgery, she was just under follow-up by her surgeon. She didn't actually see her gastroenterologist. And then her surgeon calls me up and he wanted me to see her because she started to complain of this 3-month history of painful ulcerated lesions around her ileostomy site. And what the surgeons did, they saw these lesions, so they tried to biopsy them, and then that sort of made things worse, and the lesions became more florid and deeper. And the biopsies really didn't tell him anything, tell him much. It just showed some non-specific acute on top of chronic inflammation with ulceration, and there were no granulomas. The surgeon did a CT of the abdomen and found no deep-seated collections or fistulae, and the patient only partially improved with topical and systemic antibiotics. Next slide. So these were the lesions when I examined her in clinic. So this is the stoma, the ileostomy, and then you can see these painful regions around with the mucopurulent exudate around her stoma. Extremely patient. She was in extremely painful. She was in agony. And then part of the exam, so I tried to look around and see if the lesions are elsewhere. And if you can see, they weren't just localized to her stoma, but this is another lesion that was seen on her flank that was away from her stoma. So she actually had more of these lesions elsewhere in the body. Next slide. So then on direct questioning about her IBD, because remember she's got a bit of colon left, she's also started complaining of bloody diarrhea around 3 times per day with urgency. So proceeded to do a flexible sigmoidoscopy, which showed erythema, friability, and multiple ulcers up to the visualized diverted colon. And histopathology was reported having a mild to moderately active ulcer proctitis. We discussed it in our MDT with the pathologist who didn't want to commit to whether this ulcerative colitis or a diversion, although they favored more of a diversion picture, but there were also changes that were fitting with IBD. Next slide. So I think the questions we have here, the first question is really, what is the diagnosis? And then what are your treatment options? So you've got 5 there. You've got topical calcium, which will depend on your diagnosis, topical calcineurin inhibitors, rectal 5-ASA, steroids, anti-TNF, dapsone, or something else.
Great. So maybe we'll stop here. Pause there and have some discussion. And there's really probably 2 issues going on here. So one, we have the skin lesions, and we'll first start talking about that, but then also how we handle symptoms coming from a diverted rectosigmoid in a patient. So I guess maybe Dr. Sharara, we can start with you, and what's your differential? I think we have probably some leading diagnoses here, but what are some of the other things you think about when you see skin lesions in a patient with a stoma? You're muted.
Nice case, Talal. I think the kind of lesions, of course, there are multiple skin manifestations in IBD, but these particular lesions being, present in distinct remote areas, not your typical erythema nodosum in the lower extremities, or, really gets you to maybe one of 2 things. I mean, a vasculitic process or a pyoderma gangrenosum kind of presentation. Clearly, you can have peristomal disease in a patient who's diagnosed with UC, who might have Crohn's or have such. But I think the fact that she has this metastatic or distant lesion, let's say, in another part of the body that is not close to the stoma, kind of narrows that down significantly.
And what's your approach with management of pyoderma, is this something that you manage yourself as the gastroenterologist, or is this something where you're referring them to the dermatologist for treatment? What's your general approach?
I think generally speaking, just we've gotten good experience with this disease, really. I mean, the problem is, as Talal mentioned, a lot of the times it's misdiagnosed, gets treated with debridement and antibiotics and injection of, sometimes different things. But I think we've gotten to be comfortable with these lesions. Actually, they're pretty responsive if you choose the right treatment. They're not that difficult, such as, maybe hidradenitis suppurativa might be a more complex lesion that requires surgical also input. But I think these kind of lesions are usually responsive to treatment.
And Professor Sannour, what would be your first attempt at therapy for this lesion that we're seeing, or these lesions?
Well, as Ala mentioned, probably treating, although knowing that pyoderma could really be independent of the disease, but we still use the same medications. So we have the anti-TNF, we have very limited data on the other biologics, but probably an anti-TNF is the treatment that I would have given first in that case.
And Dr. Elawali, so this patient had received infliximab before their surgery. Now, let's say that we want to put them on an anti-TNF. Would the fact that they had received the infliximab previously impact your selection of that? If you were going to use it, how would you approach using it?
Right. Thank you, Ben. By the way, I'm having connection issues. Can you hear me well?
Yep, we can hear you.
Okay, perfect, because I can't see any of you. But yeah, I think restarting him on infliximab would be a good option. The only thing is we would have to be careful with antibody formation. And so typically the way we do it is we would give them a first dose, but we would actually, before even doing that, letting them know that there is a high chance that they may get a reaction, or that they may actually already have developed immunogenicity and that it may not work. And so I kind of try to set the expectations. And then what we would do is we would give them one dose of infliximab, and then a week later check for antibodies. And if the antibodies are really high, in that case, you cannot continue with it. But if the antibodies are low or non-existent, what you can do is essentially definitely make sure to put them on combination therapy, and typically just give some steroids as a pre-medication for the first few infusions. And this is someone I would monitor antibodies closely. I would definitely do some proactive TDM there.
Right. And this is a common clinical scenario, even separate from this, where, infliximab may be the drug of choice for a patient and they've had prior exposure. So important to think about the antibody formation. Dr. Kutubi, in terms of the rectal symptoms that the patient is having, how do you manage that in a patient who's diverted?
Well, again, you can try local therapy, like pentazole enemas, and give him the 4 grams and see how he's doing. If he's not, then he definitely should be back on the biologics, on the anti-TNF.
Right. So hopefully, if we're using a systemic therapy, that may help with some of those rectal symptoms. But I think maybe Dr. Altawil, we can go to the next part of the case and see how this develops.
Yeah. So next slide, please. Yeah. So I'll talk about a little bit about sort of the, obviously the diagnosis is pyoderma. So I'll talk about that a little bit in a couple of slides, and we'll go back to the case. So as we're all aware, external manifestations are pretty common in IBD patients, and we really have to ask them in each of our clinic visits, and up to half of our patients can have some kind of extraintestinal manifestation, and some of them may even predate the IBD, and you can have a variety of them. Some of them can be more acute, like a venous thromboembolism, and some can be chronic and debilitating, like a primary sclerosing cholangitis. And the risk of having extraintestinal manifestation increases with longer IBD disease duration, and having a pre-existing extraintestinal manifestation predisposes you to having another one. They're generally more common in Crohn's versus ulcerative colitis. There are some differences in gender, for example, the ophthalmological maybe in female, and the biliary or spondyloarthropathies in males. Now, the issue about whether they correlate this activity, there is some conflicting data out there. although I think they point that most do correlate with the disease activity, except maybe the uveitis as arthropathy, and there's some uncertainty about the PSC and the pyoderma. But in general, we always try to get the luminal disease under control because that does get most of our intestinal manifestations better. Next slide, please. So in terms of pyoderma, it's a pretty actually rare disease. The incidence around the prevalence of 5.8 cases per 100,000 adults. And the prevalence in IBD is around up to 2%. And it's seen more in ulcerative colitis compared to Crohn's disease. And it's a vasculitis of the dermal arterioles that gives you the picture. And exactly what happened in our patients, you can get pathergy. And that's how they're diagnosed sometimes. They get biopsied and biopsied, it just keeps getting worse. And you don't get much findings on your histopathology. But it's useful, as I said, to exclude really other causes, I think. And there are many subtypes of pyoderma. So there's, and this particular patient had a peristomal type, which is one of the recognized types of pyoderma diagnosis. Next slide, please. And in terms of treatments for pyoderma, obviously there's topical things that our dermatologists use, topical calcineurin inhibitors, but there is a common drug that we both share with our colleagues in dermatology, which is infliximab. I said, because it's a rare disease, there isn't a lot of high quality data out there. And the only RCT that we have is really this one that was published in Gut around 2006. And it was of 30 patients with pyoderma. They randomized to placebo versus infliximab, a single dose of infliximab with a primary endpoint of clinical improvement at week 2. And as you can see, just with a single 5 milligram per kilo infusion, you had around 46% of your patients improve. So you can see like a 40% delta there between them and the placebo. So really a significant difference despite the smaller numbers, small numbers in the population. Next slide. So in terms of sort of guidelines we have there, there is the ECHO guideline on extraintestinal manifestation. They do have a recommendation there. So they recommend that pyoderma is treated with systemic corticosteroids, infliximab or adalimumab, based on more observational data for adalimumab, or topical oral calcineurin inhibitors. Next slide, please. So back to our case. So the patient was actually discussed with the dermatology, and we decided to start with oral steroids and topical tacrolimus and see how she does. So actually, both her IBD and her pyoderma were induced into remission with this therapy. However, after tapering off the oral steroids, the pyoderma flared again. And we invited the dermatologist to our MDT to discuss this. And given that this patient had active skin disease despite topical therapy, she's steroid dependent. And she had previous prolonged exposure to adalimumab before her surgery with loss of response. So she already had adalimumab, tried it for a year at least, and then received 1 dose of infliximab before the surgery. We felt, given the best data that was with infliximab, to really carefully try infliximab with an immunomodulator and pre-medication as well. So the first infusions went well. She actually improved significantly with the first infusion. However, she developed a pretty bad infusion reaction after the second one, and we had to stop it. Next slide. So I think that brings us to a bit of a therapeutic dilemma here. So what are your treatment options now? So this patient's been exposed to adalimumab in the past, had an infusion reaction to infliximab, which she was also exposed to 1 dose before her surgery. So what are our treatment options? A third anti-TNF? Should you go out of class with ustekinumab, JAK inhibitor, consider stoma reversal? And then the second question is more about her GI disease. What will you do regarding her residual diverted colon that's been left there for years?
Great.
So we will stop here, Ben. Yeah.
So maybe we'll start first with Dr. Al-Alawi. What would your treatment option be in this patient who's had the prior exposure and infusion reaction to infliximab and then also adalimumab?
Okay, so first of all, are we dealing with her bowel or her skin right now? Because I think dermatology should make the call for the skin. And if not, then we concentrate on the bowel, maybe controlling her with out of class. I don't think after infliximab, the third like symphony or something will work well. So out of class, I wouldn't have a problem with either secukinumab or JAK inhibitor because we have no data on either, and we don't have much to rely on evidence-based. Regarding the rest of her bowel, now I had a similar case where my patient was diverted like 12 or maybe 14 years back, and had a problem without the pyoderma, of course, just a problem controlling her bowel. And my surgeon was not very happy, but not reluctant to divert her. Given that the surgery was a long time ago, he was a bit more comfortable diverting her. So this, I think, should be discussed with the surgeons as well. And your patient is a bit complicated because her tummy is not that clean. She had a very bad surgical history before her colectomy. But maybe involving the surgeons regarding diversion might work. Otherwise, we need to resect the rest of her bowel because it's a source of a problem. So why is it still there?
Dr. Sanor, what are your thoughts on the treatment option for the pyoderma, and then two, sort of your management of a diverted rectum?
Well, regarding the pyoderma, I've had a case and I've checked, then again, no evidence, but I have cases that responded to vedolizumab or even to secukinumab, but those were case report, hoping that there is a parallelism between the pyoderma and the intraluminal disease. Otherwise, as it was said before, we should ask the dermatologist to give us his opinion about it. But I think that we could go with another biologic. We have to, or if we consider another anti-TNF, then we definitely should be adding the Imuran or immunosuppressors with it, because we consider that probably this case has already antibodies against the infliximab, and we should be given a combination anti-TNF with immunosuppressors. So anti-TNF with immunosuppressors or any other biologic. Now for the diverted rectum, now if I remember, I haven't had a case like this before, but maybe we could, if we consider it a diverting or colitis, I think that short chain fatty acid enemas or even formaldehyde or something like those weird old things, I don't know if they could work. Or at the end, I don't know if it's feasible in this case, a full proctectomy and let's get done with it.
Yep, I agree. I think in terms of the treatment of the pyoderma, I think one of the keys here in what was presented is that the pyoderma did respond very well to the first dose of the infliximab they received. So that's giving you a sign that TNF inhibitors are probably still a good therapy for the pyoderma. And the issue was more an antibody issue from their prior exposure to the infliximab. And the prior adalimumab use was in the context of their colitis, not so much the pyoderma. So I do think TNF inhibitors, the other ones available, whether it's golimumab or certolizumab, would be an option for the treatment of the pyoderma. Now, that's not necessarily going to take care of the proctitis from their diverted colon. Certainly, short-chain fatty acids could be a symptomatic therapy, but I do think we have to think long-term in a young patient about what their risks are going to be from keeping that rectum in there. Their cancer risk is going to be very high. When it's diverted, it can stricture down and it may make it more difficult to survey. So this is something where you may want to get multiple surgical opinions in terms of whether it really would be too difficult to either remove the rectum, make a J pouch. I think it's going to require some complex multidisciplinary team discussions in terms of what's possible. So in the interest of time, maybe Dr. Al-Tawil, you can take us through sort of where you went from here.
Yeah. So next slide, please. So I'll talk a couple of slides about sort of divergent colitis, and then I'll let you know what we did, and what happened to our patient. So, sorry. So basically, I mean, divergent colitis is basically what happens when you defunctionalize a colon, when you bypass a colon. And it's not really limited to IBD. So it can happen to any patient that undergoes any kind of diversion for any disorder. However, it does appear to be more common to occur more often in patients with underlying inflammatory bowel disease. And it's the point Philippe mentioned is quite true. So the postulated hypothesis of why this happens is because of it's thought that diversion of the fecal stream results in a deficiency of the short chain fatty acids that are important for the colonocytes, and this can interfere with the gut flora and have a role in development of the diversion colitis. Next slide, please. So what's the worry about divergent colitis? I mean, because a lot of patients are asymptomatic with it. Is there any issues in leaving the colon diverted for a long time? Well, I think the point I think Ben mentions that these patients can stricture. So the diverted colon can develop a stricture. And this is seen to be higher in patients underlying IBD, with up to 30% reported in the literature. And this actually makes it difficult, other than harboring malignancy, it will be difficult to survey that diverted colon. The other thing that it's pretty rare, but also came across literature is they can develop IBD in the in-stream colon that's proximal to diverted segment. And this is rare, but it's thought to be the hypothesis that the leukocytes are sensitized in the vascular diverted segment and then recruited to the susceptible proximal mucosa. So that can happen as well, but that's pretty uncommon. And then there's the risk of dysplasia and neoplasia, and I'll talk about in the next slides. So next slide, please. Yeah. So if you look at there isn't much data. Sorry, previous slide. Go back. Yeah, this one. So if you look at the literature, there isn't a lot published regarding the rates of colorectal cancer, dysplasia, and diverted colons. There is data for IBD, but not for diversion. And I think the biggest study that I came across is actually from Johns Hopkins, from Mark Lazarev's group. Was published in IBD in 2018, and what they did is it was retrospective. They looked at all their patients that were with IBD that were undergoing colonic resection from 1990 to 2015. Around 154 patients, so that gives you around 754 diverted patient years and around 2,000 patient years of disease. So next slide, please. So yeah, click please. Next slide for the animation. Yeah. So if you look at their data, what was interesting is that in their entire cohort, there was only one case of ulcerative colitis of cancer that was seen in a patient with ulcerative colitis, and there was no cases of cancer in their Crohn's patients with this is diverted cases. And in terms of dysplasia, there were 2 cases of dysplasia, one in ulcerative colitis and one in Crohn's disease. So it wasn't really a very high incidence there in the diverted colon. And their calculation, when they calculated diverted segment cancer rate, was around 0.5 cases per 1,000 patient years of disease. And if you actually compare that to population-based data, I think a lot of work has been done by Charles Bernstein from Manitoba, looking at epidemiology of IBD. So there's data published by Bernstein's team in Canadian IBD patients was around, and the non-diverted rectal cancer rate is 0.439. So it's very similar to the non-diverted cancer rates in IBD compared to the diverted rate. So actually the rate that's published out there is not really very high. It's very similar to the patients with IBD. Next slide. So back to our patient. So she was rediscussed in her MDT and with the dermatologist present. And because of the dearth of data for other than infliximab for pyoderma gangrenosum, but given the good response she had to the initial dose, we decided to switch to an agent that will target both ulcerative colitis and her pyoderma. So we switched the patient to golimumab, along with oral steroids. So finally, we managed with difficulty to get her off the oral steroids after dose escalation of her golimumab to every 4 weeks, in combination with maintenance with topical calcineurin inhibitors. And then we discussed the other issue of the diversion and whether to undergo a completion colectomy with the patient. And she was very reluctant to proceed. So her surgeon was she was in the UK, and he told her it's going to be a very risky surgery. So she decided not to go ahead with the surgery. And however, she did agree to undergo regular surveillance for the dysplasia with flexible sigmoidoscopies. Next slide. So this is the before and after treatment. So this is the picture I showed initially with the ulcers, and then this is, you can see how nicely healed the ulcers are after treatment with the steroid induction and the anti-TNF, and then she was maintained on the topical calcineurin inhibitors on the lesions with very nice results. Thank you.
It's a great case, and I think again highlights the importance of multidisciplinary care of these patients. And the other thing I would add that we didn't necessarily talk about was is the importance of working with good stoma nurses, because a big piece of this is the care around the stoma to limit any skin damage that can be a nidus for further worsening of the pyoderma. So they really do play a key role in managing these lesions. So we're over time, and we apologize for that, but I'll turn it back to Professor Sharara to close the session from here.
All right, thank you, Ben. I want to thank you and Flo for again moderating. Great session. Thank the both presenters and the audience and all the moderators who contributed and who also some of them were not really questioned, but hopefully we'll get them more involved and increase the number of people involved. So I think we'll see you all again on September 13th for the third round, and I wish you all a great summer.
Thank you very much.
Thank you. Goodbye.
Bye-bye.
Thank you, guys. Take care.
Unique gut selectivity of Entyvio contributes to the favorable benefit-risk profile observed. Entyvio is an integrin antagonist that binds to the alpha-4 beta-7 integrin, which is expressed specifically by a subset of gastrointestinal homing T lymphocytes. Entyvio is superior to adalimumab with respect to achievement of clinical remission and endoscopic improvement in patients with moderately to severely active ulcerative colitis. 383 patients were assigned to receive intravenous infusions of 300 milligrams of Entyvio versus 386 patients were assigned to receive subcutaneous injections of 40 milligrams of adalimumab. The primary outcome was clinical remission at week 52, defined as total score of less than or equal to 2 on the Mayo scale, no subscore higher than 1 on any of the 4 Mayo scale components. Varsity study results. At week 52, clinical remission in overall population. Entyvio provides 40% more likely clinical remission than adalimumab in the overall primary endpoint. At week 52, clinical remission at anti-TNF naive population. Entyvio provides 40% more likely clinical remission than adalimumab in anti-TNF naive population. Endoscopic improvement at week 52, overall population. Anti-TNF naive population. 42% higher endoscopic improvement in patients in the Entyvio group than in the adalimumab group. Entyvio achieved clinical response as early as week 2 and surpassed adalimumab in week 6. Entyvio is superior to adalimumab in achieving absence of active histolic disease at week 52 in ulcerative colitis, based on GBO score and Robarts index.